Welcome, welcome, welcome in, everyone. Welcome to Care Concierge with Carepatrol, where education is the heart of everything we do. It is a glorious day here in Birmingham. The sun is shining. I hope the sun is shining on you in your life and situation and work day. Thank you for joining us and making us part of your day. We appreciate that, just as we appreciate your referrals of folks who are in crisis, who need someone to talk to about what's next, whether it's discussing what Medicare does or doesn't pay for, or how to qualify for Medicaid, or how to research nursing homes, or if it involves touring assisted living homes. This is what Carepatrol does. This is what we appreciate you for helping us to do, which is to provide folks with our information so that we can help them at no charge. So thank you all for joining us today. Today is an ethics course, so make note of that. I know that those are very highly desirable when you are looking to renew your license. So today is an ethics course, and I appreciate you being here for it. And I wonder, as we are starting up here, how many of you have taken philosophy in college or in high school or in some other way? Maybe you audited a course. And by this, I don't mean like an ethics course that's a professional ethics, course, but more of a philosophy, sort of general 101. And we do encourage discussion with Care Concierge CEUs. In fact, we want you to discuss with us. We think that when you add your voice to mine, it makes for a much more enriching experience for everyone who's listening. If you're not familiar or you're new to Zoom, the way that you join the discussion is to either move your cursor up to the top of your screen and a bar pops down, or down to the bottom of your screen and a bar pops up. On that bar are the words chat and an icon that looks like a microphone. Click on the icon to unmute and add your voice to mine. Click on the chat button and you'll see the box come up with the chat on it, and you can say hello to Sharon Chestnut, Deborah Dixon, Sedina Ward, Keldon Jones, and Bailey Wright, who both took philosophy courses in college. Ann Binko and Jan Blake are also with us, and we'd love for you to add your voice to everyone's. Let me see what's going on here. Here we go. So again, I mentioned that I'm with Carepatrol. We are a placement agency, and we offer education to those people who offer out help to us. So we try and bring value to you just as you bring value to us. The best way to think of us is like a real estate agent for assisted living. And like a real estate agent, we never charge the buyer or client. We are paid by the seller or community. So that's how we work. Thank you, everyone, for saying hello. Let's get into our housekeeping. Today's topic is a long topic. And the reason I asked if anyone had taken, Clarence Merritt took philosophy a long time ago. The reason that I asked if any of you had taken philosophy is really twofold. One, I wonder if you recall how philosophical arguments are written. You may remember that in a philosophical essay or treatise, hello, Jason, and Deborah took philosophy in undergrad as well. When you make an ethical argument, the first 2/3 of that argument you dedicate to promoting one position, a position. The latter third, the last part of your argument, you completely refute the first 2/3. And then the winning argument is in the last third. And so I maybe overthought this, but I tried to construct this presentation in that manner, just to add sort of zest to the fact that it is an ethics course. So we do encourage discussions, and those who've been with us, and many of you have. Hello, Christine Townsend. She's had philosophy as well. Kim Frazier has not. I appreciate everyone who's been with us before, and you're probably used to our process, which is using SurveyMonkey, a website, to do evaluations. And generally, we will give out the website and then give out a password at the end of the presentation so that people can complete it. And in this way, we can show to the Board of Social Work Examiners that this is a live or face-to-face CEU and not a recorded CEU. That's the reason we do this way. But today, unfortunately, the website SurveyMonkey is down. So I want everyone please to make note. In order to receive a certificate, in order to receive this hour, you must email me to ask for the link, which I will forward to you as soon as the website is functional again and I can get it out. So one more time, I generally at this point am reading the SurveyMonkey address. Today I'm going to read you my email. Make note of it, please, and email me so that I can send you the evaluation link so that you can receive credit for this hour. My email is sbarnes@carepatrol.com, and I'll spell that. It's S, B as in boy, A, R, N as in Nancy, E as in Edward, S. Barnes at Carepatrol, C as in cat, A, R, E as in Edward, P as in Paul, A, T as in Tom, R, O, L.com. Please email me, sbarnes@carepatrol.com. You can go ahead and do that now, and I will send you the link when the SurveyMonkey link is working. And at that time, then we'll upload nursing hours and everyone will receive a certificate. Our objectives today are these. We're going to first define and broadly discuss, what is medical futility. And I look forward to your comments. We're going to detail a current and leading bioethical argument that is in a proponent of medical futility. And then we're going to discuss counterpoints to that in the way that I mentioned earlier, in the bottom half of this presentation, let's say, or the last, not even half, but last part, we will begin to look at maybe some other ways to achieve medical futility or to approach it. So how would you define medical futility? And as you know, I don't mind you speaking over me. In fact, I encourage it. So if you want to discuss something, just start talking and I'll eventually hush. And if you want to add something to the chat room, please do. And if you're all stumped and you don't understand or don't fully know how to define medical futility, then let's get into that subject. Ashley Talbot says she's stumped. I'm surprised by this. So physicians can enact or employ this concept called medical futility when they feel that they need to justify a decision not to pursue certain treatments that may be requested by the patient or the family. And what medical futility means is that proposed therapy, whatever it may be, should not be performed because available data show that it will not improve the patient's medical condition. And so every one of you know and have experienced that some folks, some patients have no chance of survival, but very little chance if they were treated. No survival if not treated, and little chance to survive if they were treated. And so for a number of years, a number of medical ethicists and physicians have argued that treatment in these cases is medically futile, and that it is a matter of physician discretion. And it is at the end of life, and someone said this came up during COVID, it's a growing challenge to palliative care and end-of-life care because we have to get to the point, which anyone working in hospice knows, how do we define futility? How do we define medical futility? And is it when, or how do we define that life-sustaining treatment will be futile, in other words? And then how does one communicate that? That the treatment would in fact be futile if undertaken. So the best or most debate centers on, both in today's debate and in the past, is centered on how to best define medical futility. And, I would think that this is where you all may have been stumped. Many physicians can see, they know it when they see it, right? They know it when they see it, but there's no consensus on a definition. In fact, they can't define it, but they know it when they see it. But what this leads to then, from the outside looking in, is that medical futility is undefined, and it is therefore really more of a social interaction or power struggle for decisional authority about the life of the patient between the physician and the surrogates. And anybody, I'm older than most people, but back in the 80s, there was a senator from South Carolina, and there was a case in court. I believe it was Larry Flint, and asked the senator how to define pornography, and he said very humorously, "I don't know, but I know it when I see it." And so I say that just as a humorous aside to what we all know. There are some things we know internally that we cannot put into words, and yet we know them. We know them. These are often the things we tell our children that they don't listen. So medical futility remains controversial, clearly, obviously, for many reasons. And one reason is that some physicians will claim treatment as futile without actually studying the data. And so while the definition of medical futility is that one would not pursue treatment because the data shows X, there are some physicians who do not consult the data. So they're making, in essence, an arbitrary, or maybe not an arbitrary decision, but a decision that lacks data support, data-driven support. And there's no unanimous idea of what that statistical threshold would be if there were data for something to be considered futile. And then again, you can see that this would lead to strife with the family. Tiffany Smith says, working with patients in the MICU and with patients on ventilators for an extended period of time in general, this topic is extremely relevant. I'm glad. Thank you for saying so. So then let's distill down a host of articles and a wealth of information in two sort of arguments, or two sort of things. Current discussions about meanings of medical futility, revolve around two concerns. They're related, but not the same. One is whether it is even possible to define medical futility in a way that enables objective, which is to say data-driven statistical evidence or assessment. And then who should be the determinant in whether a treatment is futile or not. We're going to look at the work of Howard Brody in this. This will be our first 2/3, y'all. Howard Brody is maybe the most well known, maybe it's not correct, you wouldn't know his name, but he's the most prominent of American bioethicists who are currently working. He was a professor of medicine at the University of Texas, and he is the author of Medical Futility and Physician Discretion. And he is the author of a number of papers. You can Google him, and if you can get access to his articles, they're fascinating. And let's look at his definition, because his definition really is the overriding definition. It is one that generally his cohorts support and reference. Darla Dean has a question. If current standards allow two doctors to determine the need for medical procedures, wouldn't the same hold true for medical futility? That's a great question, Darla, and I would assume that it would, but let's go back to like the ER. So if you're in the ER and you come in, would the doctor in the ER be working in concert with another doctor? If so, then I would expect that this would be true. If not, then I don't know that it would require the second doctor, but this is where I don't know. I will look into it and try and have an answer when we do when I send the evaluation links and certificates. But Mr. Brody says that the judgment of medical futility is purely technical and that physicians are uniquely qualified to make that judgment. And moreover, that physicians need not consult the patient nor the family to determine their values before making the decision of whether to treat or not to treat due to medical futility. Now, in Brody's mind, professional integrity dictates that treatment should not be undertaken. And he has a very interesting way of approaching a discussion of integrity, and we'll get into that. But the underlying the professional integrity that he holds so dear are two moral principles. One concerns harm, and the other concerns fraud. And he says that because medicine is both a profession and a social practice, it is therefore, because of social interaction, right? Social practice, because of that, it is capable of breaches of professional integrity. In other words, that the physician might be swayed by the argument of the family member or surrogate, and that this would be a violation of the physician's integrity, knowing as the physician does, because the physician is the uniquely qualified to make the determination that this is medically futile, that to do otherwise is a breach of his or her professional integrity. And he believes then that when the odds of survival are low, this is an ambiguous word, low, that treatment then would be a violation of that same professional integrity. So I'm going to ask y'all, and I encourage discussion again by unmuting and joining in, or by entering the chat room, as you guys have been great to do today. Is it ever possible or acceptable not to treat a patient who wants treatment and who will certainly die if not treated? It's just kind of a slam dunk question, isn't it? It's
This is Hardella. My heart says no. I couldn't refuse them. That's my heart. I don't know. Be difficult. It would be difficult.
Right, and you can see then how you could be compromised if you believed in Brody's definition of your integrity as a clinician, how compromising then you could be, and how something could become amiss. So I'm glad you made that point. Darla Dean says it's absolutely permissible. Kim Frazier could not refuse care. Alice Alexander says that you should do what is morally correct. And I think that's true. And that, again, this comes down, doesn't it? This is the crux of this argument. Who defines and how do we define futility? So Brody lays out three arenas in which he can see, in each case, medical futility being the correct course. One, and this makes sense to anyone, especially those of you that have worked in the arena of EMR services, you know that when there's a disaster of any type, that the need for treatment is greater than the availability of clinicians to do and provide treatment. So patients are triaged, and those whose chances for survival are slim, again, ambiguous, might be justifiably denied treatment in favor of those whose chances are better. Does anyone, Jennifer Calder, you hit this on the head. She said, depends on circumstances, mass casualty triaging and tagging. So we can all agree, I think, is this true? Can we all agree that in these cases, in medical triage cases, one has to invoke medical futility? Does that make sense? Lindsay Sparks says yes. So the second case that Brody looks at is more nuanced and political. And let me say that I generally do not like to have political discussions within these CEUs, nor religious discussions, nor any discussion that might divide. I would prefer that we stay on topic, but this is Brody's example, and so I will read it. He says that if the treatment that would be life-sustaining or saving involves a procedure or an outcome that a physician has strong ethical objections to, then it is permissible not to treat even if death is the result. And to Brody's example, he says if saving the life of a woman involves aborting her pregnancy and the physician thinks that abortion is morally wrong, then the physician need not operate according to that person's sense of their integrity. This is a subject of much political discussion, debate, and courtroom drama. We'll not get into it, but it is a unique perspective on medical futility. Now, the third example would be this. If there is no need for triage and there is no life-threatening pregnancy, but we know death is inevitable, and we know death is inevitable in the near future, whether or not we administer treatment. There are bioethicists, so I don't want you to think that Brody, while he's a leading voice, is his side is the only side. It's not. There are many bioethicists that think that treatment should be administered if the patient or surrogate request it, period. Even if the chances of lessening the condition or saving the person's life are zero. But even in this instance, those bioethicists agree that the concept and application of medical futility is solely in the eye of the physician. Now, sometimes the physician may decide not to treat someone absent these three instances, even for not being compensated, which I find horrific nonetheless. There is certainty that death will occur. And I just sort of added this slide to show you some of the other names of folks that write in this genre, which are Schneiderman et al. And Miles and others who hold these views that I'm relaying now. So what is y'all's opinion so far of the Brody approach and argument about medical futility? Do you know enough yet to have an opinion? Gut reaction, do you say, yes, I agree with this Brody fella, I think he's got it nailed around medical futility, or no, I have some questions about this. I think there are some outliers, and I think it's a little bit still convoluted. So yes, yes, yes. Oh, those were the last answers. Forgive me. So as I move along, what is your opinion of the argument so far? If you have one, you may not know yet enough to have one. According to Howard Brody, if a treatment is futile, then the physicians have no obligation to provide treatment. And moreover, families and patients have no right to demand medical treatment. The physician can make a reasoned determination that a DNR order should be in place and written without any knowledge of the patient's values when doing so. And in an example, the decision that one would perform CPR is unjustified if it falls entirely within the physician's technical expertise. I'm not sure I understand that statement, y'all. I got confused by what I wrote down. But here's, oh, I'm sorry, I'm missing some great comments, y'all. Let's go back. Keldon Jones says, no cookie casers, unfortunately, probably insurance driven. Sharon Chestnut needs more information. Thank you for being honest. Darla Dean says, ultimately, medical futility should be discussed in layperson's language with the family client. They must have a say in the informed decision making. Dana Kelso says it's a slippery slope. Bailey Wright thinks the family and patient should definitely be consulted in the decision-making process. And at the very least, that the patient should. Hardella Morgan still has questions. Jason Leslie says, what are Brody's rationale justifications? You'll need to give me a more nuanced or a better question because I'm not sure I understand that, Jason. I apologize. I have some questions. So far, I think Brody's approach is too narrow. The physician can walk away, the family has no voice, and they live with the outcome. Tiffany Smith says, I honestly believe that social work ethics and medical ethics are not congruent. Social work values focus on self-determination and informed consent. How interesting. What a great point. Jennifer Calder says, advocate the voice for the patient's family's wishes. She's an advocate for it. And nothing about without me. I'm not sure what you mean, Ms. Alexander, but thank you for adding to the discussion, everyone. Get my cursor going. So Tomlinson, one of the names I mentioned earlier, would support Brody in saying this, that communication with the patient or family should aim at securing an understanding of the decision the physician has already made. Note that, already made. Eliciting the patient's values or involving the family in the decision is not required. Rather, the discussion should inform them of the medical realities and the reasonableness of the DNR order. Now, Tomlinson does add that the physician should not be cruel or callous, and if the family is adamant that they should, agree to perform that procedure. CPR is a good example. But still, it's a little lacking if you think that in this view, the physician alone makes this decision. There is no consent or even consultation with anyone affected. Oh, that's great. I love the way you phrased it. So now she's explained it, y'all. Miss Alexander had said nothing about without me. And I said, I don't understand. And she said, she corrected and not corrected. She explained it for my feeble brain. No decision about me without me. Include me in all decisions. So y'all, nothing about me without me. Is that a known thing, or did you come up with that, Miss Alexander? I love that. Nothing about me without me. That'll be our Friday mantra for the rest of the day. Nothing about me without me. So I ask y'all then, is claiming medical futility a physician usurping the life and death decisional power that properly resides outside the physician? Tiffany Smith agrees with Alice. Sharon Chestnut says yes. Based on what I'm hearing, Jason says, Brody makes statements of what is or is not permissible. However, what value premises does he use as his foundational basis? That, Jason, I do not know. His value premises, or maybe as we continue our talk, they'll become elucidated to you and you can instruct me. And that is one of the things I enjoy about these is I learn so much. If the MD does refuse treatment, Ms. Anderson says, they should at least be able to provide a referral, right? one would expect. I think, but this is, yes. Now that you mention it, yes. Yes, so is claiming medical futility simply a physician's usurping life and death decisional power? But let's, y'all, in your comments, have all in unity. Lindsay Sparks says, not all doctors are created equal. Giving doctors all the decision-making can be quite a dangerous thing, especially with some. This is true. And this is the point, Lindsay, that I was hoping you would pick up on. Thank you for making it. Everyone on this call in your responses has essentially made the statement or endorsed the statement through being here, in effect, that for you, or for being a social worker, that being if the patient or family values are relevant, and we've just said we agree that they are, patient and family values are relevant in decision making about end of life. By that statement alone, by definition, medical futility or claims of it cannot be effectively instituted without any knowledge of the patient's values or without involving the family in the decision. So it then follows that the physician should ascertain the patient preferences in each case. And if the input from the family or surrogate or patient is relevant, then clearly there's need for discussion. And so then that leads us now to wonder, to state that it's difficult knowing or believing in family values. And I don't mean that in the political sense, but in believing in the values of individuals for the right to treatment, for example. It's difficult to maintain that there's no medical benefit if something falls within the physician's expertise. In other words, if you know the procedure, are you not bound to provide or offer it? Well, this may hit your question about values, I think, Jason. So Brody, Darla Dean says the cultural and religious morals values of the client family must always be considered in medical decision making. Thank you. For Howard Brody, the breaches of professional integrity would be, for example, CPR for a patient whose likelihood of remaining or regaining consciousness or being discharged is less than 1%. He believes it would be a breach of a physician's professional integrity to prescribe an antibiotic for someone who has what appears to be a viral infection. This would be a breach of that physician's integrity. Jason Leslie, it seems as though the Brody perspective is inconsistent with the social work value of respecting the right of all human life. Yes. Ashley Talbert, my mom was very ill, and her hospitalist and primary physician said that the only thing that could save her was a blood transfusion. She is a Jehovah's Witness and is strictly against receiving blood. I worked with elders and found another physician who was able to successfully treat her without using blood. That's wonderful. Wow, that was a statement. What an advocate you are, Ashley, for her. To perform a cholecystectomy for a patient who doesn't have gallbladder disease or any sign of disease, to prescribe Latril for cancer, or prescribe steroids for a weightlifter. All these things in Brody's mind are breaches of the physician's integrity because they know the treatments to be inappropriate, if not outright, fraudulent. Inject a lethal dose of drug as a part of a state execution. This is interesting, isn't it? So you would think from Brody's argument that he does not value human life. And yet one of the breaches of integrity for Brody is to participate or even to witness and execution. And so that's not where the hangup is with him. It is, like most ethicists, a mind thing. It's not a real thing. It's an abstraction. It's an ivory tower view of things. And it's easy, I think, to have these sorts of sweeping statements from your University of Texas office. It's different if you're in the ER, I think. And then lastly, and this is obvious and I won't go into it, but if the physician would be breaching their integrity if they were to involve themselves in any sort of sexual interaction with any of their patients. So those are Brody's definitions of integrity or breaches of. And so I would say then, if it is a violation of a professional integrity clause or belief or thought system for a medical doctor to prescribe an antibiotic for a viral infection, then that leaves open the possibility that it is permissible for the physician to offer to do so. So you can't require, but that doesn't mean that it's not still permissible for the physician to offer an antibiotic for a viral infection. And this is a microcosm, if you will, of the end of life debate, right? So how many of you, when feeling bad, or maybe when you found out you had COVID or just were sick and went and got tested for COVID, and they didn't yet know it, like me, I was prescribed 2 courses of antibiotics for a viral infection, COVID. And so it's just as much of a breach to Brody as performing a state execution or saving someone's life when medical futility as a concept, as a hammer, can be invoked. And so while it may be wrong to be required to do something in the ethical argument, it does not mean it is wrong to offer to do or wrong to do. There's a lot here if you're into philosophy. You have to get yourself around the notion of the verbiage and the way that verbiage is used in philosophy, like in law, to very succinctly drill down to certain points. So again, what he's saying is that if it's a violation of professional integrity to prescribe an antibiotic, that does not mean that it is still not permissible or that he cannot not still do so. Do you see? And so I want to ask you then, well, that was the wrong one. What I wanted to ask you here was not that, but rather, do you agree with the statement within the medical field that because it might be wrong to require something, it does not mean it is wrong to do or to offer to do? Can you think of any instances in your lives or practices in which this might be the case, that it was wrong for you to be required to do something, but it was not wrong for you to do it? And if you see the shade of meaning here, you can see that it might be wrong for you to do CPR under the medical futility argument, and yet it wouldn't be wrong for you to do it. Does that make sense? Doctors, nurses, and social workers are ethically obligated by their oath to do the right thing. That's true. This is where the concept of medical futility, to me, hits that physician ethic in the face. Oh, here's what I meant to say. Nope, wrong. So Brody says again that in all these cases, whether it's administering CPR, whether it's offering an antibiotic, whether it's giving steroids to a weightlifter, the treatment and requiring and offering treatment violates standards of professional integrity because treatment would do no good for a patient. This is true of giving a weightlifter steroids or of giving an 88-year-old woman CPR, and or disturb, upset, or destroy normal function or condition, and or promote abnormal or harmful function or condition, and or aid and abet ethically wrong or illegal activity. And that's the statement. ethically wrong. This is how he can hold these two counter thoughts. Something might be ethically wrong. That does not mean it is still empirically in his mind. Oh, here was the slide. Would it be required to do? It's not wrong. Never, we pass that. So what I would say here, this juncture, is that the proper role of the physician, as you all know, precludes the deliberate taking of human life in a non-life-threatening situation as a form of punishment. Doing good to humans, or at least not harming them, such as assisting at an execution, violates the norms of medicine or project wrong, harmful, or distorted images of the physician and medical practice. And so medical futility to me is a hang-up. It's an ethical dilemma for every physician. Yes, Darla Dean says it. It contradicts the Hippocratic Oath. And yet it's a concept that is employed in our lives. So why would Brody think it would violate professional integrity to require a physician to administer CPR if the likelihood of the patient regaining consciousness or being discharged from the hospital is less than 1%? Brody says physicians ought not administer treatments that cause harm disproportionate to any foreseeable benefit. So you can see in this case, if you had an 88-year-old and her likelihood of survival seemed low, she would inevitably die. It would be wrong for you then to wreak havoc on her body, break her ribs and sternum, and injure her, bruise her internal organs, when this is not going to give any great relief, prolong her life, or any foreseeable benefit. And so to him, physicians ought not fraudulently misrepresent that because they have the knowledge or skill of performing CPR, that it is and ought to be performed in every case, and that it is beneficial in every case. And what Brody continues to say is when physicians administer treatment in an appropriate circumstance, they do more than simply treat an individual patient. They are proclaiming in the sort of Platonic philosophical sense that the treatment is medically indicated and it is correct in those circumstances. And so again, he's saying, as relates to CPR, that it is not medically indicated under the circumstance that we are in. An 88-year-old woman rushed to the hospital who's dying. Darla Dean says, I once had a client with brain CA with mets to the bone. He was alert to self only, and his family made all medical decisions. He was full code. While the consequences of chest compressions were explained to the family, they hoped for a miracle and wanted to explore all options. Their wishes were respected. Deborah Dixon says, adult child died from pulmonary embolism. EMT continued CPR for 20 plus minutes under physician's order for family's benefit. This was so beneficial for the family. Deborah, I hope this was not your family. And so Brody's argument then is designed to show that physicians have no obligation to provide medical treatment. There's a duty not to perform CPR, but again, and this is our counter argument to Brody, a duty not to do something means that doing something isn't permissible, but not having a duty to do something leaves open the possibility that doing something is permissible. Think about that. Here is some hope for those of you who are losing hope. So the President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research recommended, and there's their insignia on the screen, that CPR would benefit an incompetent patient, or even if the benefit of CPR is unclear and a surrogate favors treatment, then treatment should be administered. So the President's Commission says in cases of medical futility, in fact, you do respect the wishes of the family and you do perform treatment. Tiffany Smith says the right thing is often subjective. Here, that's the point, which makes it difficult to say what is right and wrong. It's not universal. And if you cannot universally define it, can you invoke it? Ms. Morgan agrees. So Brody, again, back to CPR, says that agreeing to perform CPR is fraud because the physician knows in this case that it will not save this woman's life. And that is deliberate misrepresentation, lying in effect, or withholding information. And if a patient is truthfully told that the chances she will survive are less than 1%, fraud has not been committed in Brody's sense. So in this case, the physician, so long as the determination is she has 1% chance of surviving, then the physician can not perform CPR. And in fact, if they're truthful about it, then it would be in the larger society, it would be representing a medical practice, again, representing a skill that is not appropriate in every situation as being appropriate in every situation, if you follow that line of thinking. So the answer, the retort, is simply that the physician or clinician in this case, in having a discussion with the family about medical futility, would simply be clear and transparent. So the appearance of fraud then to Brody would be that no matter what the patients have been told or thought or heard, and no matter what patients want, physicians have a duty not to prescribe something of no value, not to engage in worthless treatment, not to raise false hopes, and possibly to educate along the way. To Brody's mind, medicine is a public institution. To treat a patient, therefore, is a public statement. Treatment, therefore, has symbolic significance. And it says that this treatment is medically appropriate behavior in the context. Again, to Brody, when you have CPR, when the odds of survival are under 1%, then that is not appropriate in that context. So the retort would be that when the odds of survival are less than 1%, that is not true. To treat under those conditions then is to make a fraudulent misrepresentation, regardless of what the patient has been told. And so I want to ask you all, and you've already answered this, really, many of you, but I'll ask again, is it a violation of integrity for a clinician to perform a needless intervention? And does that apply to medical futility? Yes or no? I'll look for the yeses and nos. I probably won't read them if they come in a flurry, but I'd be curious to what you think about if you believe it is a violation of a clinician's integrity for them to perform a needless intervention like CPR on a dying 88-year-old woman. Does that apply? Darla Dean says, I'm guessing Brody is every personal injury and medical malpractice attorney's dream. I think so. But there's a company here in Birmingham that provides malpractice insurance. They should probably have Brody be their sponsor. Like, in fact, he could like put it on his suit, on the back, to be like, I forget the name of the company. So my belief, there's a difference in all of these instances Brody has raised, in that prescribing antibiotics or removing someone's gallbladder or giving a cancer patient Laetrile are of no medical benefit, zero. And the odds of there having any effect on the client or any measurable positive effect are zero. This is not true with CPR. The chances are, in this lady's case, that it won't help, but the chances are not zero in this hypothetical. And if the odds were, say, not 0% or 1%, but 50%, we would all agree that we would perform CPR, that it was a necessary and appropriate intervention given the circumstance. But to say that the number can be quantified as 1% and not 0 is to sort of conflate CPR with these other cases that he brings up. They don't mesh. They don't have the same effect on someone. And based on professional duty not to do something, not to raise false hopes, not to make false representations, CPR still, in this case, with this 88-year-old woman, could be of some worth. And the hope raised on her part or on her family's part is not necessarily false, because she's not 0%, she's 1%. And in this case, then the education can really, truly be one that's experiential for both. The physician may elect to do CPR without success. The family will have had their wishes honored in doing CPR, and it will be a bitterly sad experience when the CPR does not work as it was predicted not to do. And so, more than anything else, we would say that it is the patient's life to lead and the patient's death to die. Any concern about anyone's integrity, a physician or anyone else's, does not outweigh the individual's rights to life and death of their choosing. And if there is some possibility, however small, and the patient wants to take it, it is not, in our mind, for the physician to say that a patient, 1 out of 100, and there are about 90 of you on this call, so one of you, we're not performing CPR, but still a patient would have lived, instead die because of this, and not the patient's decision. Physicians should not decide that for them, for the 1%, or for the other 99%, that they have no choice. Jason, are you trying to speak?
No.
Okay, I beg your pardon. There's a little light that keeps flashing. So for physicians to arrogate decisions to themselves just because they are doctors is a violation of the professional code of being a medical doctor. So I would ask y'all then, let's define what's the best approach to determining medical futility. Is medical futility something we can or should determine? What's the best approach, y'all? I'd be interested in your thoughts as we're winding down the afternoon. What's the best approach to address or determine medical futility? Well, I would say this: medical futility disputes. Jennifer Calder, Darla Dean, excuse me. Patient and family must be part of the final decision-making, Ms. Dean says. Jennifer Calder says patient family wishes will need to be respected. 1% chance is still a chance. And there's hope within that 1%. Miracles in medicine happen, they do. Keldon Jones says he wishes he did. I would say medical futility disputes, and that's what it is. Remember, we said at the beginning, it's really from the outside power struggle, are best avoided by optimizing communication. Isn't this true in most every arena? Don't we say this about many topics that we present? Communication is key between the physicians and the surrogates. And the physicians should be encouraged, and I know they do or should, provide families with accurate information and frequent updates about the condition. And I don't think that happens. Assure that the physicians address the emotional needs of the family and try to understand what the family is going through and thinking about this patient who appears to be dying. And then we think that we have to have a very flexible definition of futility that is patient-centered and reliant on goals of care as morally preferable to the integrity of a discipline. So, and we would even push forward the notion that the concept of futility, medical futility, as a means to resolve disputes around end-of-life treatment issues, may, in fact, itself be a futile exercise. Can we ever define it to our liking? Statistically, what does it look like? How do we agree across all practices, clinical backgrounds, settings? How do we come to that? And if we can't come to that, then do we drop the notion altogether? We have a password with our survey evaluation tool. Again, email me sbarnes@carepatrol.com. When SurveyMonkey, the website, is working again, I'll email you evaluation link. I'll give you 48 hours to complete it, and then I will send out the certificates and post nursing certificates. Again, we're accredited by the social work and nursing boards to offer these. And we post nursing certificates on the ABNP website for you. Social workers, you can still post your own. And the documents are Word documents. So you social workers can type in your name and license number. Or if you fail to do that, just keep the email that I send you so that you can prove to the board you were here live. Alice Delois Alexander says she had a great aunt whose daughter had signed the forms not to resuscitate with the hospital, but she coded. Her daughter wanted the hospital staff to resuscitate. Isn't that interesting? Great discussion. Thanks for everyone's input. Ashley Talbert, Darla Dean, love this. Thank you for your comments. Thank y'all for being here. Clarence Merritt has a message to me, but he says, unfortunately, the subjectivity of subjectivity of family understanding is compounded by the fact that so many times treatment decisions are being made at a time when the family is grieving and anxious. Another reason to educate families about advanced directives. We have a bit of an ethical duty to educate. The Conversation Project is a great example of how to do so. Those of you that are still with us, look up the Conversation Project. Thank you, Deborah. Thank you, Julie Shink Brown. Can we make the debt 72 hours? Yes. Oh, it won't be. I don't know when it'll be probably Tuesday or Wednesday, Julie, to be honest, before I close the survey down. Christine, thank you, Christine. We're actually working on my February calendar now. I should have already done it, but I am going to do another ethics course, probably another one on dementia, and I'll try and dig up some other things. But I'm going to put my email address in the chat box per Ms. Chestnut. Thank you for reminding me. Let me see. I used to have it. There it is. If you do not email me to request the link, I have no way of knowing you were here and you will not get credit. Please email sbarnes@carepatrol.com. sbarnes@carepatrol.com. Thank you all so much. The password is 1%. We have an ethical and moral obligation through the 1 in 100% chance that someone may have of surviving without this treatment, or even with. So we owe it to the 1%. It's 1 with the percent side, no space. I'll put it in when I send y'all an email, I'll put the password in. Jennifer Calder wants to revisit Deborah Dick, yeah, I always add my courses to the, or I don't, but they do, add them to the social work site and the nursing site. I also send out an email. If you're not getting my email, let me know with those on it. And you can also go anytime to my website, which is carepatrol.com, and click on the picture of me there. It is me. It doesn't look like me. It was 10 years ago. I had brown hair, but it is me. Click on that picture and you'll see a calendar as well as some things you can watch from the past if you need other CEUs. And you can also go to YouTube and search Sean Barnes Care Patrol, and there's about 50 videos there. So thank y'all, everyone, for being here. We're at 1 o'clock. I will call the meeting to an end. Y'all have a great weekend. Thank you for being here. Thank you for Care Patrol, for supporting Care Patrol, and for referring your clients, friends, and patients to us. I'm terrible with technology, y'all. It's embarrassing. Come on. Well, I need to keep talking. Thank you, Dana. Thank you, Mona. Thank you, Jennifer. Thank you, Natalie. It's very kind of you to comment. Thank you, Jason. Jason, I think you're new to us, and thank you for being here. Good to see you all.